Right, let's get cracking. Alrighty, everybody, welcome back to another episode of the Sports Medicine Project. Now, most of our listeners, we think, listen to the Inside Running podcast, so you're going to hear a familiar voice in Michael Nitschke. Now, I'll give a very short intro and let him introduce himself, but he has a decade of clinical experience in private practice and exceptional anatomy knowledge. Now, very rarely do we get someone on here that's a health professional. So he's a podiatrist working in a specialty sports medicine clinic and also a running coach. So I'm really interested to get a little bit of a background at how he blends the two and I guess some amazing insight. But welcome, Michael. Thanks for coming on.
Thanks for having me. I was saying I've listened to your podcast for a while now, and the other podiatrist who works here, Matty Clark, who's an Olympic podiatrist in the steeplechase, he's a big fan of your podcast as well. So yep. So I'm excited to be on today. So thanks for having me. So
yeah, I was just we were just saying off air, we put up a poll on the Instagram, just to see if there was any listener questions. And, we usually get a few, which is normal, but, we had 6 or 7 in like 30 minutes. And I was like, oh God, we're gonna have to make 8 episodes just thinking into a series. This guy's popular. But yeah, so what do you do? I know you're a podiatrist, but tell us about the clinic you work at, your coaching. Yep. What's keeping you busy?
Yep. So I've been a podiatrist. I graduated in 2006 now from UniSA in Adelaide. And so I'm from the country originally and moved up for education purposes. And over the past 6 years now, I've worked in a multidisciplinary clinic here called the Sports and Arthritis Clinic, where the leads are a pair of exercise and sports physicians. And we also have a lady going through the registrar at the moment as well. But we have allied health, dietetics, we have physiotherapy, and a personal training unit upstairs as well. So it's a nice facility to work in. And we're about 6 years in now, which means 50% of our time working here has been during the COVID period. So it's been tricky in terms of a business development and process. Obviously, allied health had different sort of regulations compared to medical. So trying to reconcile that during that sort of early COVID period was character building stuff. So
yeah, and you just I've found, and we've both found in the clinic, so many people are just rescheduling and moving, and there's no excuse. If you've got COVID or influenza or whatever is going around, you're seeing them 2 weeks later, and then it's tricky, definitely tricky.
Absolutely.
So what's keeping you busy outside the clinic at the moment?
Yeah, so look, probably the last 5 years I've been coaching more so as well, in particularly athletics, so cross country and athletic season. I've got a good group here in Adelaide who run for the Adelaide Miles crew. I've got an assistant coach in Annie Kiddo, and we've got around about 20 to 25 runners who are, we would say, between elite to sub-elite type runners developing. So we help organise their trainings and have group workouts a couple times a week, and so that definitely keeps the busy part of it as well. But to be honest, the biggest change in my life the past 2 years, we've got a daughter who's 2 now, Zara. And so my wife and I have moved to the hills, to the foothills, so running is really nice. The trails in our backyard in the national park, Bel Air, which is the second oldest national park in Australia. And so that's been really nice, but that has changed the game a bit in terms of my own running. And my focus towards more clinical practice and coaching has been definitely the priority. So.
Yeah, that makes sense, because I'm always on your Strava and I see you're out in the hills, and I was like, why does this guy just go on the flat? Come on.
Yeah. Look, it's literally the backyard, so across the road into the area, and I've really enjoyed it. It's definitely changed my shoe selection recently, but it's been fun. So.
I can't picture what SA's like. I need to get there, because I've heard, I picture it as being just a normal city. And then I hear things like that. I'm like, wow, that's really different to what I imagined.
Yeah, it is good. We've got, obviously the CBD is really flat, and most of our runs in the city are completely flat, and we've got the hills nearby. So it's a bit of a cycling mecca as well. So you've got the cycling, only 30 minutes away from the CBD, even closer. And that's why the Tour Down Under is so successful here. When you see the footage, in January, you've got some decent climbs through the Adelaide Hills. Not that the drivers love it, but it's it is good for trail running as well.
Yeah, awesome. All right, well, let's get stuck in. Kelly, you want to lead us off with the first question? Now, we'll say that out of all the questions, and they're all great, obviously, this question is going to be my favorite. I'm excited to hear this answer. So you want to read us through?
Yeah, sure. So you're a clinician and you're a coach. So that's as we've sort of said before, a really unique blend of having the best of both worlds, particularly with the group of patients that you see, and also with coaching runners. Where do you think these two sort of different professions and areas can sort of learn from each other? And then also, where do you see mistakes being made from individual sides of the story as well?
It is a good question, and this is the one that you did send through, and I was trying to think about the best way. I've always found it quite difficult to understand why there is such a demarcation between the two, coaching and allied health, perhaps. And a lot of the stuff we do ends up being very educational, and a lot of the time as a coach, that's the most thing. While you set up a program, like a weekly schedule through micro and macro cycles of running with your coaches, you are dealing with human beings a lot of the time as well. So I still find clinically, while there's a lot more value from a patient perspective put onto allied health more than, say, I guess perhaps coaching. But I think it's because people in allied health clinics are to some extent coaching a little bit anyway. And the skill set of coaching is probably more intuitive, or it's discussed to be more intuitive and less scientifically based, whereas as allied health practitioner, we tend to practice by evidence-informed decision-making, don't we? We definitely are seeing in coaching now evidence-informed decision-making as well, but the application of doing that in coaching is very, very much artistic, so to speak, meaning, you sort of how you get a scientific approach across to an athlete dealing with a human being, consistently changing from day to day. There's more art and science involved in that. So I would say a lot of the stuff I've done in coaching, or maybe the way I moved into coaching, was a lot of the times people would come in with, say, a running related injury. It's still the most common thing that I'll deal with clinically. And sometimes injuries are unavoidable with, just the musculoskeletal load involved in cycling, so running compared to cycling or swimming or non-weight bearing sports. But I remember reading this article in 2005 saying, it could be a chance that all running related injuries could be avoidable if you can just get the load perfectly right. So trying to tease out this perfect load management strategy for an individual, that's where the art is, right? Because the science for that doesn't seem to be truly clear. But it did make me start sort of thinking about the way to manage injuries in terms of almost like a hierarchical approach. What's the first thing I would look at to triage a running related injury? And no doubt it was someone's training characteristics and how they organize their weekly schedule relative to their experience, but also their injury history. So I think that's coaching. But I also think it's a big thing that we should do in the clinic as well to be able to have the best outcome. And I guess the hardest thing is when people come to see a podiatrist, the other pillars, which include things like the way you move, so biomechanics or tissue strength or capacity, and even footwear, which is really fun to deal with. People come in thinking that this is going to be the answer to be able to solve my problems. And look, it plays a role, absolutely. But I would argue it doesn't play quite as much role as sort of organizing the relative training characteristics for the individual. And it's hard as a human being to say, well, I put my hand up and say it was my training errors that caused my injury. No one wants to hear that, do they? So it's easy to say we can just put a shoe on or change the way you move a bit or get you a bit stronger, and this will hopefully sort your problems long term until you overdo it again, right? So so I guess maybe the clinical stuff and dealing with lots of running injuries sort of saw my interest in the coaching. So the two are really closely related. But the one thing I've learned is coaching's given me time to work with one particular athlete over a long period of time. And while I see that a little bit clinically, I definitely don't see patients I would often see regularly, a couple of times a week for many, many years. So I'd argue the intuition's a bit more important in coaching, but the evidence-informed practice to be able to give patients the tools to look after themselves is probably more important in the clinic.
Yeah. And do you think, and like you were saying, like 100%, I know we both definitely agree with, I guess, the low hanging fruit of, looking at someone's training load. Do you think that clinicians, whether it be something they're just not confident in doing or whether it be an ego thing, like I remember starting off as a clinician, I would thought I could do all the coaching and return someone to running and return someone to the level that they want to be. But I think now, getting someone out of that kind of calming down phase, I'm like, go and see your coach and they look after everything because they know so much more. Do you think that's worthwhile for clinicians to do, like get them to a certain point and then be able to say, great, go with the coach, they can look after all the training stuff? Because I'm not confident with that.
And what point would that be as well, do you think?
Yeah, that's a good question. So look, we have some great coaches here in Adelaide who I think putting them as part of the process is a really important piece of the puzzle in terms of managing the load. Like different types of injuries and histories of injuries relative to the person and the training characteristics, what they need to get their goal. Sometimes there's a point in the training program where the specific training they require, they can't actually handle. So say, for example, a track runner who's managing Achilles problems tends to be provoked a lot more by the quality of running, the intensity. And for a block of time, you say, well, actually, you might have to wear this for a period of time, and you can do a lot of low intensity work without provoking it, and then titrate the speed work in. I think coaches really appreciate that if they see success attached to it. And look, as a lot of my athletes who I coach, I tend to get to deal with a lot of their load, but I often say, I need to send them off to other practitioners for a bit more advice, say the sports doctors that I work with. And they're really good with sort of giving me suggestions in terms of how I should manage the load or modify the load temporarily. So what time do you place the coach in as an emphasis, or they take over? It's probably built on how confident the coach is and how confident the practitioner is as well. And also trying to make sure you're not stepping on too many toes. It can be difficult. Really good athlete that comes through the doors. Often them and their coach know exactly what they're doing, and the load management strategies in place are probably pretty good. Not always, but probably pretty good. So dealing with those finite details of like tissue strength and mechanics, and trying to get some of those 1%ers done are really important for that cohort. But often when a novice runner walks through the door, look, you're probably trying to deal with the low-hanging fruit of low-hanging fruit is probably the hardest one to discuss, but the training frequency and training volume ends up being more important for them, because the 1%ers aren't really worth looking at yet.
Yeah, that's true. Yeah. What would you say to the patients who are, say, returning from more risky injuries, such as like bone stress injuries, who have set time frames that they want to get back to races? Like how do you have that conversation with patients?
It's good. I had a couple from New York Marathon coming up soon, because that's obviously an expensive trip as well, coming off the back of injury and trying to find it. Like, it is complicated. Like, you need to meet them halfway a lot of the time. And then you need to work out if that person's going to have more future opportunities to be able to have a crack at something similar in the future. And, maybe suggest to them that at this point in time, this is a bit risky, but you can do this one, 8 weeks down the track. So knowing how the sport works and knowing other events and trying to basically meet someone halfway is important. But in terms of actually getting someone back to a particular load, you're always trying to get them to like a minimal dose that gives them the biggest effect to be able to complete their event for their relative goal, aren't you? And so you're trying to subdivide the time that you have relative to the injury that they had as well. And look, I still think that's a bit more art than science at this point in time. But look, I'd say we're pretty lucky in the fact that we have so many running opportunities now that often when one event is really close by, let's say it's a UTMB or something that sort of, you can probably complete the event without causing too many problems if you give them the minimal amount of dose of training. But then you have to lower their expectations of performance. If someone's going to go and try run the New York Marathon and say, well, look, I've got 8 weeks to go. I haven't run for 16 weeks because of this femoral stress fracture, and I still want to run sub 2:30. Well, then you've got some, talking to do to that patient and say that, to get there, it's going to be a real Hail Mary. But if it's someone just completing the goal, for example, and they paid $10,000 on the trip to get there, look, you're trying to get them to complete the event. And so once again, it's goal setting, isn't it? And then it's trying to find that particular amount of dose, and that dose you give them is basically built on their experience as well and their training status historically. Like, someone can have time off, but have a rich history of running and get back to more dose quicker. And someone can have no history of running. So if you increase their dose of an injury, the risk of re-injury becomes really, really high again, doesn't it? So look, that's a huge factor.
Yeah. And talking about dosage, and again, I think all these questions are going to have a bit of an art and a science. How do you calculate kind of appropriate load management when progressing someone's running? And, I guess the common examples are the acute to chronic workload and 10% rule. What's the answer there, which I know is the complex one? Yeah,
it is. And it's a good one to discuss, because I don't think people discuss this one quite enough. And, it's funny on, social media these days, give a good platform. People look for this magical answer or this unicorn of load management. And, the 10% rule, which was, sort of discussed in the 1980s, which was sort of debunked by the group over in Run. I think it was the group in Denmark, Rasmus Nielsen's group, just sort of found that the 10% rule wasn't really here or there. And then you hear the 20% rule as well. And then the acute chronic workload ratio, because I guess when you just sort of, kilometers aren't just kilometers, are they? They're relative to the individual. And once again, like I said, history You've seen runners who've come back from 4 weeks completely off, and within 4 weeks progress back to a volume that's probably been similar to what they've done, prior to the injury, and get away with it. And then you see other people get nowhere near 50% of that load within 4 weeks and then not be able to get away with it. Mm-hmm. And maybe that is the density of the injury, other risk factors associated. But in terms of an actual formula, I think knowing that kilometers aren't kilometers is a really, really important piece of the puzzle. So, when we look at training characteristics, we divide them into the frequency, so how many exposures you have through the week, intensity, so how hard that relative effort is, and duration, so the time on feet as well. And then this gives you a global volume. So the acute chronic workload ratio, you can go back all the way to the Eric Bannister model, where they tried to measure, essentially fitness and fatigue, which I think historically was a 50-day cycle of load would form your fitness load. And I think it was a 15-day cycle of effort that would form your fatigue. And they would divide, fitness or fatigue from fitness, and they give you what they call a form or a readiness score. Mm. And that was a predictor of performance, which unfortunately has been shown to be not a huge predictor of performance. And then Andy Coggan, he was famous for creating the TSS score, which is used in Training Peaks. And he did it by utilizing power. And power was such a accessible tool for cyclists to measure their effort, that they would basically use a functional threshold power, which would describe what you could do for about an hour. And you'd get a certain amount of points depending on how hard you would cycle. So, 100 points, so riding at your threshold for an hour would be 100 arbitrary points, or objective points in this case. And you would measure your load over about 28 to 42 days and divide it by your 7-day cycle of fatigue and give you a form point. And that would hopefully predict whether if your form is really, really in the negative, your risk of injury and illness or performance might be low. If it was really, really positive and your fitness was low, but your fatigue was high, you're not going to perform very well. And so these values were trying to predict performance first. And then I believe Tim Gabbett took that sort of TSB type cycle, which was created by Andy Coggan, to create that to try and predict injury. So over a 28-day cycle of loading compared to a 7-day load of cycling, your fatigue fitness model created this predictor of injury. And it's great to see it on a graph, but dealing with people in person as to sort of, the common sense paradigm, one person can increase the dose by 30% 1 week and have no risk of injury, but that's relative. That might be from 20 Ks up to 26, right? So, and that would be 20 to 30 Ks. So that would be a 30% increase in load. And that might not be a big deal compared to, say, someone who's been running, that same person might have run 50 Ks a week historically. But you take someone who's running 120 Ks a week and say, let's give you an extra 36 kilometers for the week, can really tip the boat, can't it? So it's the exact same absolute formula, but the marker of fatigue for that individual probably is still better measured subjectively. So to answer your question simply, if someone's a novice athlete, you're always trying to give them the minimal dose in the early days, because usually some degree of work will make them improve. And people that feel like they have to progressively overload every single week, I don't know if that's necessary. Sometimes you can keep the dose the same for 5 to 6 to 12 weeks, keep it consistent, and, physiology adaptations may not plateau either. So, maybe you're trying to find a halfway point and say you're going to try and get 3 frequencies per week. We're going to increase the duration of a few of these until we feel comfortable and life allows that. And then when we get to closer to your race, we're going to, leave that stress there and add some stress via the intensity. So, and different injuries respond to different characteristic changes as well. That's another one.
Yeah, it's so interesting, isn't it? Because I'm personally, I know the acute to chronic workload ratio, and that kilometers aren't just kilometers, as you said, intensity is such a big factor. And then for me, I've just forever struggled with hill running, so that's something that I need to be really conscious of as well with my training. But then it's still you fall into the habit of looking at your Strava graph and you're like, oh well, this week I haven't done that much, so I could run 30 kilometers this weekend and I'd be fine. But then you pull yourself back in and realize that you're being ridiculous. So it's funny, isn't it?
It is. And I've always historically, I think it's built on the history. So I've historically had sort of lower leg related injuries, which I think are highlighted more by the history of intensity running, being a shorter track runner. So when the dose gets out higher in that area, I can sort of flag a few tendinopathies and calf related issues, but I can probably collect a lot of volume and not get too many issues. But unfortunately, I don't physiologically respond quite as well to it as I do to the intensity work. So it's like a halfway point. I think I wish my physiology responded better to a bit more volume, but it doesn't quite as much as the intensity model. So like I struggled a bit with the marathon blocks. I've run 2 of them, but really enjoyed the process of it. But, you know, I thought, I'll break 2:30. I ran a good preparation for it, ran 2:33 for the marathon and blew up. And then I went back and ran an 800 last year at the age of 36 and still broke 2 minutes for 800. And I did not train for it. So, and I don't want to run 800s anymore because they're hard. So, so I think it's built a little bit on the physiology and I guess your history of it as well. So,
Yeah, and I guess experienced runners probably do have a pretty good understanding. I remember like and I've only been graduated now 2.5 years, 3 years, and you know, seeing runners now, like they have such a better understanding than what most clinicians think of what works well for them. And obviously that's incredibly important. Look,
that's really, really important. And this is definitely not discussed enough. I think in terms of, you know, education of learning about runners, like each Sunday we go for a long run between 90 minutes to 2 hours with the group. And I still think that if I, you know, times that by the 15 years I've been doing the sport, the things you learn on that period of time, speaking to different runners and how they solve their own puzzles a lot of the time. I saw a study from Ben Pedersen recently sort of showed that the athletes or runners like to self-manage their own injuries more often than not, right? And clinicians should probably advise people via online education to be able to get out to them, for example. So it goes to show that runners think they can solve the problem more often than not, but a lot of them can, which is why they do it. So I think the experience and the application of running and what you do and learn around people who've been doing the sport for a long time adds to your education of sustainability, whether it be injury risk, overtraining, or even performance.
It makes total sense because you spend so much time, like as a distance runner, you spend so much of your week running and you're often around other runners. You're talking about running. Like for us, we're seeing runners, so constantly talking about running with runners as well. So it totally makes sense to trust a runner's intuition on how they are feeling and their experiences with the sport because they've spent so much time invested in it. And, you know, if you're like, I don't know, more runners probably listen to music and podcasts now, but I know there's quite a few that don't. And you're spending that whole time probably thinking a lot about how you're feeling, how you're breathing, what your body is doing. So I agree. I think that that's probably something that's not discussed as much as it could be.
And we see this in other aspects of running related injury as well. Like a lot of these athletes who have been, you know, wearing different shoes if you're running 100 kilometers per week, for example, you're probably rotating between 2 or 3 pairs of shoes consistently. And because of the accessibility of them these days, probably 4 or 5 more than likely. They develop
6 or 7.
And they develop this nice intuition to what they feel and why they might not be able to objectively describe why the shoe works for them. They subjectively have a bit of a feeling as to what works well in terms of performance setting, but also in terms of you know, maybe the way that matches their profile and gait, for example, as well. So I think these things are important to note. Usually runners are pretty close to solving the puzzle themselves. And then we find that perhaps maybe we just need to detail it a little bit for them as well, using evidence-informed practice.
Yeah, I did want to just quickly add, I know we mentioned a couple of minutes ago, Ben Pedersen, he was my postgraduate supervisor, and he's definitely the guy to watch in the running injury research. Incredibly smart guy. He's awesome.
It's good because he's looking at some of the behavioral stuff as well, which I think is the area to go in. Another lady called Chloe Blackett here at UniSA, she's running at our running group as well, and she's running a nice study on terms of getting people to sustain running for long periods of time, meaning stay in the sport basically. And once again, using a bit of a focus on behavioral characteristics, which once again, there sort of is changing the game a bit in terms of your subjective exam, dealing with runners now, not just dealing with the objectives that we normally do.
Yeah. Wait, so you're telling me it's not just foot type that causes injuries?
Oh, don't tell everyone yet.
Now, that kind of leads us into the next question. And this is one I'm really excited for, which I think I've said for every question so far. But do you think there's value in prescribing footwear based off foot type in biomechanics in the asymptomatic population? And then also following that, how do you like to use footwear to have a therapeutic effect? And, you know, we've all seen now, you know, even foot and ankle surgeons that are recommending Hocker Bondi for people with ankle OA. So there's something to it, but what do you think?
It's a good question. I think that's been nicely debunked in the past decade in terms of literature as well. I mean, the Rasmus Nielsen's paper, I think 2014, you'll find that he was the person that basically divided at a 12-month prospective study, which we just don't get here. And he had close to 1,000 runners in the cohort. And he had people sort of divided into different foot types, but he gave all these runners basically neutral shoes, and looked at whether foot posture in a neutral shoe was going to be a risk factor, related to running-related injury. And look, this was a study that went for 12 months, and they showed that there was no change in sort of running incidents, injury incidents in that cohort, whether you're, moderately pronated. I believe they used the FPI, so the foot posture index, neutral, and a Cavus foot type. In fact, the subtle takeaway from it, the people that sort of sustained less overall injuries was the pronated foot posture within the neutral. So look, it's interesting noting that neutral shoes, and this was a novice cohort, so less than 6 months of running experience. So that's a big takeaway. And it just goes to show, once again, novice runners have more things to worry about than their footwear straight away. That probably changes with experience. If you grab someone who's running 100 Ks a week and you change their shoe from like a New Balance Super Comp trainer through to like an Ultra Escalante, a low pitch shoe with minimal midsole, and you change 100 kilometers for the week, the risk is probably pretty high, right? So but of course, the person running that sort of volume probably won't make that change. They have enough common sense normally to be able to not do that. So footwear sort of goes down the food chain for what's the most important thing for novice runners, but probably moves a little bit more to the important for people collecting more volume. But I think that the interesting point is, by the time someone's run for 5 or 6 years, they are self-regulating their footwear pretty well by intuition, or speaking to people in retail who are specialized in the area, and have developed a bit of a rotation of shoes that have been successful for them. So to answer your question, it doesn't seem like a really important thing to do to grab the foot posture and say this is where you need to be related to an attribute on the shoe. And we're seeing that in the shoe market now, aren't we? We're seeing postings disappear from shoes. I've got 2 left that have a medial post on them, and look, I to be honest, will I have a place for them? I don't know. How do you guys use a medial post in a shoe these days?
Yeah,
I guess it's just about load redistribution, right? Like if you're, and that's probably the whole idea with, or the whole, everything that you were just saying then. If you're changing from something that you've been running in a long time to something completely different, it's just shifting the load to tissues that maybe aren't used to it, and that's where you might run into problems. But Absolutely. If you're a novice runner who hasn't done anything and you're starting off quite small and gradually building, then your body's having the time to adapt to anything that you put your foot into.
And absolutely. And you've answered my next question already. Like, you basically, in relation to distributing load, like often we can use shoes as a bit of a tool to be able to do that, to keep someone running, right? And you've mentioned that. So that's probably where the evidence has been a bit better. And we probably see specialty retailers have jumped into this idea, rather than, someone coming to with patellofemoral pain, high BMI, and rather than put them into a medially posted shoe, for example, they might be putting them into a shoe that has a lower pitch to try and, not get them to search for more ground in an overstride, heel strike quite as much, but you're making a hypothesis that essentially, this person is probably overstriding and, hitting a higher heel pitch. But then if someone has an Achilles insertional tendinopathy, you might be putting that pitch back in the shoe and putting them back in that environment. So there are these nice little attributes within the shoe makeup that can probably keep someone running specific to an injury, right? And we have heaps of those now as well. You only need to look at the Hoka rockers that are quite stiff in the midfoot to reduce midfoot loading and reduce pain of midfoot OA. We've seen these shoes rejuvenate careers of sort of like 45-year-olds. Start big toe away. It's a big one as well. And, stiffer forefoot in shoes. And now we've got the performance categories of shoes doing the same thing. So.
Yeah, it's interesting. And I know you and Tom DeCanto did an awesome podcast on the Inside Running, like really recently, like the August edition, talking about a lot of the research, which was awesome. And then all the Shoe Geeks episodes.
Have they published that one?
Yeah, we'll listen to it on the way home.
Oh, nice. That's good.
Yeah, that's good. So all podiatrists.
resource, that podcast. Yeah,
it's good. It's really good. I mean, like you were saying with the shoes, and especially with big toe away, sometimes, you know, having someone in a carbon plated shoe with big toe away, it nearly brings them from like a 10 to a 0. It's incredible.
It's amazing, isn't it? Look, and it makes us look really good. So, and we've got those tools now. We didn't have them historically, right? So, I know Hoka have been around since 2009, but they were really hard to find here in retail back in that day. Whereas now they're so high up the food chain in terms of accessibility. But like you said,
I've got my Hokas, got my carbon 2s on right now.
Oh, nice. I haven't got into them yet as well. Actually, I have to, in terms of like, you know, talking about specificity of shoes, I'll give this group a shout out, but this is, I actually have never worn the Ultra before. So this is the Ultra Torrens. Ultra run their philosophy of basically having an anatomical fit.
Yes.
Which
what
means,
is that?
so it's called Ultra. Yeah. So they're not quite as popular here, bigger in the US, but the anatomical fit is a luxury, right? Like I forget how much you know, space in the forefoot really is a luxury in 2022.
Although like the I just got the Cloud Monsters, the Ons, and they have such a big wide toe box as well. I feel like they're too big almost. Like they feel so spacious.
They are, yeah. That has a huge volume in that shoe. So, and look, some of the anatomical fits are really good. I know my wife's got quite a broad foot, right? And she saw the Ultras in shop maybe, I don't know, maybe 2 years ago. And she put them on and goes, oh, this feels fantastic. Her feet can just splay out, right? But she's looked at them, and because anatomically, we don't think of this as like a really pretty shoe, because, you know, pointed shoes are probably designed to make us, that's what we perceive as a nice, you know, clean, good looking shoe. But she looked at it, she goes, I'm not quite ready for it yet. So she went into a pair of Cliftons that would, like, you know, D-width, so a bit wider anyway. So, but she's, you know, you can get the Torrent in complete black, and she put it on her foot. The only thing I find is the reason I'm wearing them, they're useful, is I pitch all my shoes. I have a history of Achilles and calf. I'm probably 16 millimeter pitch on average for every shoe I wear, minimum. So Tom's worse. Tom's probably higher, I reckon, and he's had the same issue. So it's like a methadone clinic. I'm trying to slowly work my way. And this is zero
weight off the pitch.
That's it. So I've got a pair of running ones with 6 heel, but I'm walking in them at work and things like that. So hopefully that has a bit of a, you know, transfer effect, and I can sort of get myself out of really high pitched shoes. So
I know Andy Bryant, I think he listens to this podcast as well. He's going to be loving this. He loves the barefoot or the wide.
He does, and he advocates it as well. And I remember seeing a post historically, he mentioned about, you know, sometimes getting people into them is meeting them halfway. You can offload the forefoot really well with the geometry in the shoe, and putting a small pitch in temporarily is a good starting point to get into these shoes. And look, if you don't need it, fantastic. But a lot of people have come from 10 mils. Sometimes putting a 6 beneath the sock line is not a bad sort of halfway point.
Yeah. You're gonna ask a highlight of that one. Can you see?
Ask this
Have
one.
I want to ask this one because we're starting. Kelly and I are both doing Queenstown Marathon, and we live near a big hill. And I've seen every runner that I follow post about the benefit of hills making you a stronger runner, but I just don't like doing them. I would like to get the benefit without doing them. But one of the questions we wanted to ask is, and from your like coaching experience, where do you see hills fitting into running programs, and if that changes obviously with distances and athletes and things like that?
Look, keep in mind that generally the biggest association to you doing really well in that marathon is just running more. That's the first thing we need to know. So, and the hills are specific, but I have my opinion on them, and then obviously I have nice anecdotes of people who don't use them as well. So we do a lot of long running through the hills. I am of the belief that the impact loads are a little bit lower when you start climbing a lot in our long runs. So we can normally collect more time with a slightly higher heart rate for a bit less stress. In terms of stress on maybe impact related stress, but in saying that, stress does change. So when you climb a hill, there might be more tension off your tissues that originate from different areas, right? So we just need to make sure that that's taken into consideration as well. But I'm of the belief that when you're climbing hills and you start descending them, you know, you get a small accumulation of the lactate, for example. You start changing your energy systems from utilizing, you know, fats as a fuel substrate to more carbohydrate. You probably develop a little bit of lactate clearance capacity by doing it. While it's not, you know, while it's association and not cause, a lot of our great runners, you know, the Monaghettis and lead troops and De Castellas are famous for running a lot of their long runs through the hills. And I guess the key point is that you normally collect a few more heartbeats or percentage of heartbeats for probably globally a bit less stress, I would say, in terms of tissue. That's relative to depending on what tissue it is. An insertional Achilles tendon might disagree with you, so to speak. So But I lectured at a conference recently, and the coach of Jess Trengrove, Adam Diddick, Jess had a phenomenal run at Birmingham, and the back end of Birmingham was quite hilly. And I asked him the question in relation to, because I know they don't do a lot of hills, and I felt responsible once Jess came out for a long run through the hills with our group, and she was obviously training really hard, but she ended up with a bit of a stress injury of a femur. And I felt really bad because she hasn't done any hills. And I was like, oh, maybe I've just, brought her out to the group, picked the hilly
Like, come on,
and broken her, right? But long story short, they don't do a lot of it, but they do a lot of lactate clearance specific work, which means they're running a bit above the threshold or close to the threshold. And then they're clearing it by running just a little bit below it as well. And we sort of discussed this once on Facebook, and in relation to them getting the capacity to be able to climb hills by accumulating a bit of lactic. Whether there's a mechanical effect to climbing up hills that's advantageous, I do believe there is a bit of that. Like, I've got a young lad who I coach who climbs really, really well, long levers, runs over the ground beautifully. But you normally, like, unlike cycling where watts per kilo is really important, so the lighter guys can push higher relative power, climb better, there's probably a mechanical aspect to climbing the hills, posture, covering the ground. I mean, every step you take going up a hill, the ground's getting closer to you a little bit because you're climbing up a hill. So teaching you to run over the ground probably is a subtle mechanical movement that can improve your economy up the hills. But I guess there is data similar to strength training improving your running economy globally. People incorporating short hill sprints and moderate hill sprints seems to be associated to improving your running economy as well. Whether it's better than other things like strength training or whether it's a replacement, running up a hill, you're normally running at a higher relative effort with a lower absolute pace. So it's almost like resistance training to some extent on a low grade scale. And you'd argue over Eastern African countries, they do a lot of climbing over the rolling hills and things like that. Whether the effect is partially mechanical or partially physiological, you don't like climbing, but I love it. But I'll measure it by effort. So I'll be happy to see 5 minutes on the clock at a 6% incline, for example, knowing that the heart rate for that particular duration of time is probably giving me a little bit more physiology back. So I've found that a nice way of getting back from, say, some particular types of stress injuries that I may have had historically as well, just to slow the pace down, but collect a bit more physiology.
That's interesting. Yeah, that's a good answer. And then do you tend to program them into, as you said, like into your long runs, or do you have sessions that are hill specific? Yeah, or depending on what you're training for, I guess.
The cross country on the weekend at Oakbank was for our national cross country demanded people to be climbing really hills, but looks like the mud was the biggest disadvantage there for people. But that was really hard to try and train. Think going to chase hills is hard. Going to chase mud, you can't get a group to really adhere to that. But we do normally put strength work in, which essentially is our hill work. But we won't do it super regularly. So our longer runs will collect most of the hills in that. The week that we do a longer run through the hills, we might not do as much hill work that week in terms of a program. And a week that we do a lot of climbing on maybe a Friday or Saturday workout, we might keep the long run a bit flatter that week as well. So we don't want to overload those systems. But for variety, it makes sense to be able to do it. And I still think there is probably an economical benefit to climbing hills if your race is going to incorporate some hills as well.
Yeah, cool. You mentioned the crossover between strength training and running. Where do you sit with incorporating strength programming into your running programs?
Yeah, I'm mixed about this, and you only need to jump on Twitter to look at things like the effect of how much load goes through a calf, for example, when you're running, for example, and which is what sometimes you see statistics between 5 up to 11 times the body weight going through a calf. And well, I can't calf raise 11 times the body weight. What's the transfer effect? So, isn't the best transfer effect is that I just run to make sure I get that? So. I mean, strength training still is associated to improving running economy, so performance attribute. So putting that, and I think as the distance gets maybe shorter, in terms of middle distance work, maybe the effect is probably a bit higher in that cohort compared to long distance runners. But I don't think it's more important than running more. But I guess the whole idea of strength training is maybe if you add that into your routine, it gives you the capacity in the future to be able to handle more running. And that's what needs to be looked at. But it needs to be looked at compared to other variables that people might replace strength training with, which would be, say, 1, more running, 2, maybe running a higher duration of your week up hills, for example, and seeing what the economy difference is between the two. I mean, there's small discussions on other things you get from strength training that you don't get from running. And the big ones are things might be, bone density development and, tissue stiffness, etc. as well by closed setting activities in the gym. So one of our runners here runs about 13 to 1400 meters per week through his 100Ks a week. And then the next year, he'll go to the NCAA system where he'll be in Chicago, which is flat, a cement prison, call it. But he'll have to replace a lot of the strength he gets in the hills with probably more likely a gym setting. And so, look, he won't get the economy from the hills. And look, East Africa, I don't think they do as much strength training. I think they definitely do a little bit of it, but I don't think they definitely focus on it like what Western runners would do. And they definitely probably don't consider it as much of a huge, maybe injury resistance type protocol either, which is interesting. I think most things they do in those countries tend to be built on trying to, make money and get your way out by running fast, right? So I think, it plays a role. And maybe we don't have jobs and lifestyles that demand a lot of strength throughout the day. So it gives us a good supplement for general strength for life as well. I know having a daughter that's 2 years of age and getting down on the floor for like an hour with her and then getting up, I'm like, oh, that was really easy. It shouldn't be hard at 36 or 37, but it is a bit harder. So for me, there's probably more merit to it. And we know as you get older, perhaps reducing a bit of duration of running and replacing strength training might create more sustainability. But in a younger cohort, maybe it's just getting into the habit of doing it for the future. But I'm not convinced that it's more of a variable for improving your performance than more running would do. But maybe that's built on your injury history as well. And it's also built on maybe your makeup, meaning if you want someone to get a bit stiffer when they're running, they're losing a bit of performance from that. Maybe closing down the drills and doing them in the gym setting is a good starting point, because just telling someone to run mechanically different is sometimes not achievable, right? So
yeah. Yeah, on that note, running technique, what are your thoughts on intervening on someone's running technique in an asymptomatic group?
Yeah, I think it's a tricky one, isn't it? So in relation to injury, like if someone's doing longer distance running, for example, there's usually no need to intervene with any sort of like global running mechanics, is there? But as someone starts to improve running, like if you watch 100-meter sprint final, everyone's got like almost 90-degree knees, their postures are good, they're running over the ground, they hit the ground hard. Then you watch a marathon and there's such a variation of how people get to the finish line mechanically, because that event's so metabolically demanding. Your body picks, or your central nervous system will select what is most economical oxygen wise to get you to the finish line. If that's going really well, you don't want to interfere with that too much, do you? But of course, as the event becomes, shorter or involves a kick finish, for example, and you're fit enough to go there, but you don't have a mechanical advantage, sometimes changing the way that you move for those particular parts of the sport are really important. They might increase risk of injury as opposed to decrease risk of injury. The ability to apply more force, for example, means that if you can do that, perhaps maybe you do it a bit more often than training when you shouldn't, and you might injure yourself. So, so in terms of injury risk, the only need I would see would be if someone is continually getting particular pathologies related to their gait, or you hypothesize is their gait issue. And you don't need to look any further than Christian Barton, who looked at sort of patellofemoral pain in relation to maybe that sort of braking loads, or Chris Napier's work on braking loads and sort of associating that with anterior shin load or anterior knee load, giving that gait a bit of a tweak temporarily to keep someone running, to offload that particular joint. There's merit in that, isn't there? But that's a symptomatic population, not an asymptomatic population. So I guess when you see someone run and you might think, oh, that doesn't look right. Well, then you change something and you cause a problem where you think, well, yeah, you've intervened when you're not meant to. So,
yeah, we were discussing like a patient of mine, and I've seen her a couple of times at Parkrun, and like she's so lovely. And we were just discussing, like she just asked me the question, do I need to change my gait? Because she'd had people constantly come up to her and say, oh, you need to change your knee position, you need to change that. And I was like, I just don't think, like, everything's okay. I don't think there's any merit in changing, and at the level that you're running at. Like she's not, going to represent Australia in the Commonwealth Games. But yeah, it sounds, would you agree, something similar?
Yeah, I think so. I think those patients that are super motivated, though, who have a bit more time up their sleeve, you can always consider, like, I think it was I can't think of where he's from. He might be Canadian coach, Vern Gambetta. And he talks about the use of the typical ancillary running drills, like ABC running drills, and how the effects of, say, maybe doing high knees and heel flicks in these particular drills, which they originated in Poland because, the coach in Poland, because they couldn't run outdoors during the winter, right? So they had to try and, compress running down to these particular types of drills and do them in repetition to get better at, at the sport. It's almost military-like. And you do these drills often enough, maybe there's an ancillary effect to them where, the posture position becomes a bit easier when you're doing more continuous running or even interval-based running. It's definitely more sustainable and shorter workouts and sessions, doing, say if you've got, 10 by 200, you might be able to hold on to some of these cues and attributes for that period of 30 to 60 seconds. Going for an hour might not be quite, as sustainable, but perhaps that cohort of people who want to improve maybe the mechanical efficiency on how they move. So sort of like running faster for absolute periods of time, could add some more running drills or do other things that, high performers do, like strides or hill sprints for short durations. And this physiology or even the mechanical aspects of that, there might be a small ancillary effect to it, meaning that you might start to take a bit of those attributes and fall over to some of your fast workouts, even if it's just the finish off them or the finish up a race. So, there might be benefit to adding those sorts of things into that cohort rather than just saying we're going to increase your cadence rate, make you stand taller, run over the ground, hit beneath your foot, which are all these drills that for a short period of time are very metabolically costly, and sometimes you lose adherence as well.
Yeah, I've never heard it answered like that. I like it. That's great.
I think that's good because it's giving them something to work on so they feel like they're making progress on their running technique, because a lot of runners are keen to do that, but without doing it in a way that is, as you said, metabolically demanding and making them have to constantly think about, am I running on either side of a line, or am I lifting my knees high enough, or all of those cues that you mentioned.
Yeah, absolutely.
Yeah. What would you say, and this question is more targeted towards the clinicians listening and people that struggle to return people to running. And I'm assuming, and this question is kind of based around if you don't actually do any running yourself. So are there any easy ways that you might suggest? I mean, we've talked before about, and you mentioned just before, using like frequency, volume and intensity and building that up. But what would you suggest for the person that's probably not as knowledgeable and doesn't run as much themselves?
Look, if the person's trying to get better at the running or use it for, say, health span, so get better at health, which should be most people, right? Normally, we're looking at high frequencies of activity, so more often, 3 to 4 frequencies per week, and we know that seems to be a bit of a. There was a paper by, I want to know this one, but it was like if people that ran between 20 to 40 Ks per week were less injured than those who ran less than 20. But slightly more than 40. I know the one you're
talking about.
And then those who ran like 2 or 3 times a week were less likely to get injured than, say, those who ran less than 2 or those who ran more than 4. So obviously the sweet spot, right? Yeah. So getting people to try and collect more frequencies first is where I'd normally start. And then I think if it's performance-based, well, technically the high association to performance is distance or duration more than the intensity. So we get the frequencies out first. We usually add the duration second. And then when we find a happy medium for that and they need to collect a little bit more physiology, well, then there's time to add the intensity in from there. But it doesn't mean if someone's coming back from a particular, say, a tendon injury, for example, it doesn't mean you can't add short doses of, say, tendon preparation, which might be strides and drills. It just might be titrated in really small early on. And then, then the workouts can come later on. So you're sort of trying to get someone back fit first, and then alongside of it, add a small characteristic in that is preparing that particular tissue that you're returning to get back to injury. If someone has no injury at all, well, then, I think more frequencies first, more duration second, and then you add the intensity when you truly require, and then try and make it enjoyable for them so it's sustainable, so you create the variety throughout the week. So one might be duration bias, one might be intensity bias, and one might be like, do what you feel that particular day, but make sure it's just a bit easier.
Yeah. And then having the right metrics in place.
Yep.
Yeah. That's great. What, now, impossible to answer this question. And we always talk about how common running injuries are. Like, some studies are like 79%, over a period of 6 months, incredibly common. Undoubtedly, most runners will experience one in their life. What tips and things do you give to your athletes and patients and things for them to think about? Not to say do this and you won't get injured, but more just a concept to think about.
Look, I don't want to sound like a broken record, but I think the key is you work out one why you're doing it. And most of our patients still come through the door to meet the physical activity guidelines. Running always comes across as this particular activity that's easy to get bang for your buck. And often that means is people make particular errors by going out and doing the same thing 3 times a week, same intensity, same route, same duration. And look, there's a lot of monotony in that training as well. And, Carl Foster's work historically showed when you build you create high monotony in your training, the risk of injury or illness might be a bit higher as well. And that's back in the 80s. So I'd argue that was the first true load management strategy that was probably discussed back then. And what we see with really sustainable athletes is that they spend a lot of time at the low intensity. Unfortunately, for a lot of the population, that is going for a walk, that is hiking up hills, and you are collecting, 1.8 millimole of lactate by walking up a hill or even walking on the flat. If you go out there for an hour doing that, that's good physiology and it's good adaptation. And look, I think when people return to running or get running schedules early built on, you're working where they're currently at. Not everyone can do a lactate test. We aren't all the Ingebrigtsens here. We just can't give everyone a lactate test upstairs. But look, you can get close to it. You can. I often find that with junior runners, I use heart rate as a nice guide for them with a strap to see if they are working hard on their easy days. But often people go out the door and they think if they're not running, and I use the same example, like if I, run 15 minutes for 5K, 3-minute K pace, but I'm jogging at about 4:45s or 4:30, so it's 90 seconds slower. If I have a patient come through that can run about 20 minutes for 5K, but they're jogging at 4-minute 30K pace, they're working relatively quite hard, but they might not perceive that they'll be in this, I call this sweet spot of training, that sort of 80 to 90% heart rate. We can do it for 30 to 60 minutes. It feels not too easy, not too hard. And people chase that monotony. But often you realize that when you're training a lot less intensity, say maybe 10, 20% less, you're getting a lot of physiology from it, but you're just not getting quite the same physiology. But people need to put value into that. The ability to utilize fats as a fuel substrate means you need to be working at lower intensities and, breathing out less carbon dioxide and so you're building less lactate. You get good at low intensity by exposing yourself to low intensity. You get good at high intensity by exposing yourself to high intensity. When we look at all these studies comparing high and low intensity, that's 6 weeks. Of course, someone gets better if they run harder for 6 weeks. You take someone who wants to do this as a lifespan or health span thing for 10 years, the only way that makes it sustainable is we look at people that do that for a living. And our endurance athletes who do it for a living, 80, 90% of their dose is at the low intensity. And that's arguably one of the most important points for sustainability. But they become so efficient at that low intensity work is that the pace that they can run at to utilize fat still can sometimes be 4-minute K pace for an Olympic marathon runner, but they're still below 1 millimole of lactate. So look for them.
That's a good answer. That's got me pumped up.
So trying to get people to value the intensity continuum is a really important part to getting people running more often and reducing risk of not just injury, but we're also looking at overtraining syndrome as well. People who sort of cook themselves a bit from working too hard. And look, intensity work is fun until it's not. So it's, if you hit a plateau and you're working really hard, well, the thing is normally to try and drop the intensity and add more time, right? And eventually, if someone never really gets their time. We want to get to 100 miles a week of running, this magic sweet spot, which they sort of like this fairyland which you get to. But if you can get there, you normally have to get there quite slowly, and you normally have to do it with lots of easier work. So running's easy. You run 100 miles a week, that might be 12 hours. cycling, they're doing 25 hours a week, 30 hours a week, right? So these people are really efficient. And but unfortunately, time-wise, it's a job, right? So
I love that you've said that, though. That's something that I'm constantly preaching, is just building up your running sustainably, particularly with those patients that just love running so much and they want to get back as quickly as they can, but they also want to be running for as long as they can. So it's constantly that conversation of, look, let's just build you up sustainably. The best way to get your running as good as you can is to be able to run for as long as you can without getting injured and without there being any hiccups along the way. So let's just do it slowly and try and span out and have a little look at this big picture of how many more years you want to be running for. And that's definitely something that I've learned myself, that those easy runs are so valuable, and it's completely transformed my running and my injury status as well. So I really like that answer.
And I mean, how you measure the intensity to give them the tools becomes an interesting point as well. Like, I mean, we have, I guess, 3 major metrics we use in running, and one is your rate of perceived exertion. So the Borg scale from 6 to 20, that was meant to predict like a linear increase. So like 6 out of 20 would be 60 beats a minute, and 20 would be 200 beats a minute. Unfortunately, effort's not really linear, is it? So, so the CR 1 to 10 scale became more popularized. And so your effort from 1 to 4 was about the low intensity, and 5 to 7 was this moderate intensity. And I guarantee you go to the clinic next week and you'll ask for RPEs between the runs that they do 3 times a week, it's always between 5 and 8. So it's a weird intensity. No one ever goes 9 or 10 because it's really hard, and no one goes 1 to 4 because I think they're not getting anything out of it. Yet when you go to the elite cohort, and it looks like they're spending a lot of time in the 1 to 4, and how they distribute their time in the threshold zone between 5 and 7 compared to say 8 plus is probably season dependent. So in the winter, they're building up more duration in the threshold, and in the summer, they spend more time in the high intensity. And I got a nice opportunity to look at one of my athletes' data last year. He broke the 5K junior under 18 record here. And like, he was my first athlete I coached starting at 13. And I thought, well, I need to try and develop the habits in him that the best have in the world, right? Which is usually lots of volume of running, but volume is relative, right? So, that was 20 Ks a week back then. And now he's up to close to 100. But most of it was at the low intensity, which we would, on easy days, we'd prescribe by effort. So just say it's easy, full stop. On threshold workouts, which was sort of like a sweet spot where we sort of had measured by in the lab when he got to about 16, we sort of knew that heart rate was a good guide, because in the summer here in Adelaide, it gets really hot. So you can, your pace drops a lot compared to the same heart rate effort. So we use heart rate for efforts that were like 20 to 30 minutes of work, and we just control it from heart rate. But in the track season, we would basically use pace as our metric, because of course the limitation in how fast you can run on the track is built on usually your 200 and 400 meter repeats, etc. So we use that as a marker of intensity. So the time and place to use those markers. Heart rate's a good guide, but they need to be relatively accurate, which is not a wrist strap. It's got to be a chest. But your RPE scale is good. So going in and asking, okay, what was your effort those 3 runs? Yeah, I think you'll find what they call a threshold model of training. Not too easy, not too hard. It's common.
Yeah. Now, we'll finish off with these listener questions that we mentioned that we had shot
like
through. That's what I was thinking. We might throw these at you as like a rapid fire question sort of thing. So I've got about 6 or 7 questions here. So
finish with that one, because that's a really important one that I've want to get a good answer for.
So number 1, suggestions of shoes to reduce calf injury or risk/load.
Depends on the foot strike. So look, if someone's a heel striker, usually more pitch is better to offload an Achilles or a calf. But if someone's a forefoot striker, the rocker seems to be one of the attributes that offloads the calf unit. So it helps the sagittal plane motion. That's the quick fire answer basically. So rocker offloads a calf for a midfoot, forefoot guy, and heel pitch probably offloads a rear foot guy.
Yeah. Now, for this one, I've heard the rumor is this changes every month, possibly every day. What is, and I'm going to split it into 2. What's your favorite shoe at the moment, and then your all-time greatest shoe you've ever put on your feet?
Yeah, so currently I'm wearing the New Balance Super Comp trainer, which is this high stack carbon plated jogging shoe. And I look like that's like I talked about the methadone clinic of trying to get my way out of it. That's probably there. And currently the Nike Invincible. I race in the Alpha Fly, just respond to it really, really well. So so that's my shoe. But historically, I love this shoe. It was a bit of a be all end all shoe for me back in 2001, 2, 3, maybe a bit earlier. Was the Nike Zoom Elite 4. So back then they used the Zoom foam, Lunaron type midsole, and they had a mild post which didn't do anything, but they were lightweight. They had good responsive foam. But it's like when you go watch an old horror movie from 20 years ago and you go back and watch it and you loved it when you were younger, and you're like, oh, this is rubbish now. If I put this on now, I have no idea how it
That's how I feel about the Asics DS trainer. I used to love that. And now I look at that and I'm like, oh.
Look, the Asics DS, they're going now, so it's a bit sad, but I used to love the early versions. And they used the Spiva midsole before they went Solite, and the Flight Foam. The Flight Foam became a bit heartless, but the Spiva midsole was really nice. So, but look, once again, I might put it on now and hate it. So.
How do you educate runners around footwear?
Look, it's purpose driven. So a lot of the time I'll have people getting a mileage shoe for their longer running and a faster shoe now for their faster running. The beauty of faster running shoes, they're very different to what it was when I was running when I was younger. They're high stack compliant foams with carbon plates, and not for juniors all the time. Of course, sometimes I try and get them into a hybrid, only because I think that benefits, kids are tricky because you don't want them to not have the best tool, because if all their peers beat them by 2%, you think, oh, have I just lost the race for them, and they drop out of the sport. But you always try to develop their own stiffness properties as well without the shoe. But yeah, so runners is education. But how I personally, outside the clinic, educate them. Look, I do long runs with groups now, people who work in retail in my running group who know more about running shoes than I do. Julian on our Inside Running podcast knows more about running shoes than I do from his intuition and experience. So I still think in terms of education, we go to those retailers. I send them to those people who are in field doing it weekly or doing it daily to give the best education. And I'm usually quite confident that I can do that without giving them as much education in the clinic now, which is sort of putting me out of business. So
yeah, I think in probably the last year, and our like local running shop is Pure Performance in Derby Street. And what I generally do is just write, the characteristics that I would like from a shoe. And previously I would write the exact shoe. And I'm like, these guys know so much more. Plus they're fitting them. And I'm like, you guys are going to be so much better. This is what they might benefit from, but if there's something else, go for it. I mean, you're in there with the store.
That's the way to do it, isn't it? Give the characteristic and the outcome you're searching for and let them solve the puzzle from them. Yeah.
How long does it take to lose running speed / endurance? I think they'd be different.
Yeah, to the second, if you can give us that answer.
Well, I mean, there's always data on the VO2 max loss, right? Isn't there? So I've seen, publishments of people losing VO2 max of 2 weeks detraining up to like 5-10%, but then performance doesn't drop, if that makes sense. So they'll go and do a 5K time trial and they'll be able to search it via their economy or maybe via their lactate clearance and stuff. They'll be able to manage it or deal with more discomfort or something like that. But so those markers or metrics of fitness, for example, can sometimes change relative to detraining, but it might not also relate to performance. But look, if someone's a 5K runner, you're not just looking at VO2 max, you're looking at their their second lactate turn as a bit of a marker of how fast they run as well. So their economy at those particular paces, that's so different, built on experience as well. And speed's an interesting one. I think, people that don't practice speed often tend to get, the detraining effect. For example, you don't just run 100 Ks a week. And if you don't practice speed, you'll lose your speed because you're not practicing speed. But if you're doing 100 Ks a week and you're still throwing in your drills and strides and your speed work once a week, you probably keep your speed. So, I mean, obviously time off with injury can obviously lead to detraining in terms of like speed and tissue conditioning, and then it takes time to build back up. That answers a real moving continuum, isn't it? Relative to, your experience in running, the type of injury and exposure. If someone's a high grade sprinter and they strain their hamstring, they don't do it for 4 weeks, they come back. Well, they may lose 6% or something like that, which might take them from, 10-1 to 10-3 for 100. That's a big deal for them, not a big deal for me. So so that's it's really relative to the individual. So
and then last question, and it's very hard. This is probably the hardest question we've got. When does a runner need to see someone for an injury? And somehow answering it in the sense of for runners that are listening to this, and also for clinicians and podiatrists when you have rehabbed someone and you've got them back to where they want to be, and you're not saying, because you don't want to say any pain at all, come back and see me, but you also don't want to say pain for 6 months then come and see me. It's this sweet spot. But how have you found it's worked?
It's a good question. Like obviously even Ben Pedersen might be able to answer this better, knowing that people sometimes don't even seek advice for running related injury. Some people don't seek advice for running related injury because of the expense associated to it as well. And then I guess what happens is if an injury becomes really bad, the expense of that becomes really high. So, so you're always trying to work out the best cost ratio for the patient, aren't you? And often if I'm getting people back via training characteristics, I like doing things in periods of say 4 to 12 weeks of blocks of training for them. And often if they're nice enough, they'll let me collect some of their data, and we'll go back and sit down after 12 weeks and say, this is what the habits, what you developed, this is what you had historically. This looks really good and sustainable. It looks like you're managing it really, really well, and they don't need you anymore. But a lot of people don't know the answer to that question. And I think seeing the practitioner is really needing to know the answer to that question. And it's usually built around how your training schedule is, whether it is, if you have perception that something's wrong in terms of your characteristics of training, or whether it's mechanical. Perception of mechanics seems to be the most common thing that we'll see people here, I'd say. So posture of foot, gait pattern, for example, will be reason why people would come and see you, and they may not actually be a reason to see you. So, and often that patient, you'll be reassuring them and saying, this is actually not one of those risk factors you need to be too concerned about. But hey, we've looked at your training characteristics and you're hitting threshold 4 times a week. This is something to consider. This might not be sustainable forever. Or someone who has a large history of Achilles injury or something like that, and they've added no preparation of removing their intensity, and they're doing it 5 times a week, and or they haven't prepared, like their Achilles is still sore and they're not quite sure why it's still sore, and you could just drop 2 intensity workouts per week and keep them running. Look, I think the question is why people don't come to practitioners by the time they're injured is an interesting one. And it's whether they perceive the service to be needed or not. And us as allied health practitioners, you only need to see the modern age world. In 2022, people are trying to sell the education and services quite often on social media. And so people sort of almost feel like they can grab the answers bit by bit, but it's really putting it together as the puzzle that the practitioners should be able to truly make a hierarchical approach to treating that particular individual's ailments, and try and work out what might be the most important thing for that individual. So the often is, if you don't know the answer, you probably seek someone who potentially does know the answer. And because usually you're answering an educational question that prevents injury or reduces the risk of injury, is what you're searching for. Once someone's injured, look, I mean, whether it's behavioral, which means that person might not come back to see anyone or see anyone in the first place and make the same characteristic, they make the same issue, like the same error over and over again. It's hard to fix that person without trying to change the behavior. And that's the completely different scenario. Like coaching's easier because I get to deal with the people more often. I get to change behaviors more often with more, more exposure to weekly catch-ups and running. And I think maybe that's where perhaps being a runner is quite a good thing as a practitioner in this dealing with running related injuries. It's because patients maybe have a bit more buy-in, whether they should have more buy-in, whether you're a runner or not. If someone provides perfect evidence-informed information, they should listen to it. But human nature is not to do that. So I still have lots of people coming through the door because I'm a runner. And I could probably, use that to my advantage and give people really poor advice but we don't, because we love running, and we know what it's like to be injured, hopefully and it's an important piece of the puzzle, because we try to use our intuition, which is usually experience driven, mixed with the evidence informed practice guidelines, and we can make better decisions collectively. So I usually think that's the best way to think about it. If someone doesn't quite know the answer, usually it's a very simple answer and they can fill the puzzles in for you. And that's probably the cheapest way long term. So
yeah, incredible answer.
Yeah, that's good.
God, I'll tell you what, I don't know if two podiatrists have talked for this long, and I haven't heard the word orthotics or custom orthotics yet. It's crazy.
No, we
which is
haven't.
nice, isn't it?
It is nice.
2 brands, which is good. So, and then it is good. It is good to chat about this sort of stuff, and probably discussions like this are a bit tougher to have because, look, it's hard to sell load management. It's not super sexy. And that's tricky, isn't it? So, and like I said at the start, people sometimes don't want to know that the behaviors that they had and the characteristics they had might be the most common cause of their running related injury. But if you can sort of solve that puzzle, you're changing someone's long-term sustainability to running, but also health span. We talk about that as well, that people don't hit the activity guidelines often enough. Well, look, maybe putting value into stuff that's not that difficult is something we need to be able to sell to patients. And and sometimes that is hiking and trying to
parkrun.
I totally agree. That's what I said. I was like, doctors should prescribe parkrun, not medication. I reckon.
And look, out the physicians, granted, I work with here, they are big prescribers of exercise for most things that they do here. And look, you only need to jump onto Twitter to see John Orchard sort of promote that, the exercise physicians compared to other specialists don't get the rebates back from Medicare quite as much, which is, completely confounded by people being, by your cardiovascular fitness and physical activity being the number one association to all cause mortality, right? So keeping people active is our role, and it's not always by orthomechanical and movement patterning. It's by motivation and designing people's weekly schedules and motivating them to put value into moderate, low, and high intensity work, strategically put together well.
Yeah.
What a good note to finish on.
Cardiovascular health and pronation. Great, mate. Thank you Thank you so much for coming on. And if people want to hear your voice more, Inside Running, Shoe Geeks, that's monthly, isn't it? That's right.
Yeah, it's monthly. Yep. So we'll be up pretty soon as well, which will be good. So we're talking about a few, and we're all back running again, which is good. So between the three of us, we've had ups and downs. So
Yeah. And then to people to find you, it's because I know Spark, there's 2 Sparks in the Instagram profiles. And then, so just follow both and go from there.
Yeah. I mean, look at the main Spark page is linked to the Spark podiatry aspect of it as well. But look, I'm on Twitter and things. I'm always easy to access, and Instagram, and our running group's called the Adelaide Milers Crew, which I sometimes put some load management stuff up on that as well, and share some of the data from the runners and their performances, etc. So I'm always around. So yeah,
mate, we'll have to come down and hit those hills.
Yeah,
absolutely.
Once.
Fun. Well, you need to practice first.
Newcastle's got hills, hasn't it?
Yeah, it's got this big Merriweather line, but it just sucks. And I've just started to run a little bit quicker, so I only want to run on the flat. I never want to run hills again.
Yeah. That's all right. So you measure your threshold heart rate or whatever it is, and then you try and run a hill at slower pace and sort of think of it as getting similar physiology, perhaps. Maybe
I like that.
You want to do it. Yeah,
I do like that. All right, mate. Thank you so much for coming on.
My pleasure. Thanks, guys.